So in this study, the team from the University of Washington, led by Dr. Mike Schweitzer, asked the question, if there is a concordance of DNA damage repair gene mutations in paired primary and metastatic prostate cancer samples. They wanted to establish if DDR mutations, which are seen on the metastatic prostate cancer samples, either in metastatic tissue or circulating tumor DNA, are they also present in the primary prostate tissue? So just to establish if these mutations are early truncal events or they arise later. I don't think they were surprising. I think this has been our observation also. We presented a similar abstract in the 2021 Genitourinary Oncology Symposium in our collaboration with Garden 360. So not surprising, but I think these are very practice informing data, in the sense that if you have metastatic tissue, we can reliably say that this will likely replicate the findings from the primary tissue, or if you have circulating tumor DNA tissue results, sequencing results, I think I can assure my patients that this is what we are also going to see in the primary prostate tissue and vice versa. So not surprising, but I think practice informing. Absolutely. I think role of PARP inhibitors are very clear for our patients in treatment of our patients with metastatic prostate cancer. Up to 20% or 25% patients with metastatic castrate-resistant prostate cancer have DNA repair mutations in their tumors or in germline. And with the approval of olaparib based on PROfound trial last year, and then rucaparib based on Triton-2 trial, we have these drugs available for our patients with metastatic castrate-resistant prostate cancer. Olaparib is approved for those patients who have had disease progression after one novel hormonal therapy. Rucaparib is approved for our patients who have had disease progression after novel hormonal therapy and a chemotherapy, such as docetaxel. So now we have these drugs approved, and they improve overall survival, especially with olaparib. It showed improved overall survival and radiographic progression-free survival in a randomized controlled trial. Rucaparib was approved with response rates, objective response rates, comparable to other PARP inhibitors. So we have these highly well-tolerated oral therapy options for our patients. So we do not have any reason for not looking for these mutations, these DNA repair mutations in our patients' tumor tissue or in germline. So yes, these are very important findings from the perspective of how we treat our patients in the clinic. That's a great question. People often wait for onset of castrate-resistant metastatic prostate cancer before ordering germline or somatic tissue sequencing to look for these DNA repair mutations. In my view, we should not wait. I'd never wait to sequence. I order these sequencing testing when I see the patient for the first time. We know that especially primary tumor tissue may lose the quality to allow proper sequencing. And there is a time limit for most of these testings. Most of these companies, especially commercial vendors, they do not accept tissue which is 6 years or older, more than 6 years old. Many times we know, based on our personal experience, that these tissue are not kept by the hospitals, local hospitals, for more than 10 years. And instead of waiting for onset of castrate-resistant prostate cancer, and then try to do sequencing when these tissue may lose, we may lose the quantity or quality of these tissue. I think, at least in my practice, I order solid tumor sequencing of primary or metastatic tumor tissue or both, or circulating tumor DNA, pretty much when I see these patients for the first time. And that's what I would suggest to my colleagues and across the world to sequence, do not delay sequencing. So first of all, if you look at the PROFOUND trial, this was the first randomized phase 3 trial in metastatic prostate cancer, which was biomarker based, and it was positive. So great news indeed for our patients, which led to approval of olaparib, the first PARP inhibitor for treatment of patients with metastatic prostate cancer. What we really learned from this trial was the first thing from this perspective, 30% patients were not eligible even for screening for the trial because they did not have adequate quantity or quality of tissue. So patients had progressive disease, and we want to look for qualifying DNA repair gene mutations, and we did not have tumor tissue for those patients. And this happened because those tumor tissue were either too old or not available. So the biggest lesson I learned from the PROFOUND trial, other than that olaparib is a very valid option based on a randomized phase 3 trial backed by level 1 evidence, that we should not wait for our patients to develop castrate-resistant disease before we order comprehensive genomic profiling of the tumor tissue or the circulating tumor DNA or both. I think we should order them the first time we see our patients, especially with the tumor tissue, which loses quality and many times they're not simply available after a given duration. They get thrown away, or they somehow they get lost. So I think that's a most important message, or those are the two most important messages I learned from the PROFOUND trial.